Today we are revising the jaundice laboratory diagnosis and the post-hepatic jaundice. So the important question came for the university are, what is the post-hepatic jaundice? How is it diagnosed biochemically? And next question was blood and urinary findings in various types of jaundice. And another one, obstructive jaundice. So in this question, two are of obstructive jaundice and the other one is the blood and urinary findings of various types of jaundice. So before going to discuss about any type of questions in jaundice, we have to know what is jaundice, define jaundice. So when the bilirubin level exceeds 2 milligrams per deciliter, it diffuses into the tissues, producing yellowish discoloration of sclera, conjunctiva, skin, and the mucous membrane, resulting in jaundice. So the definition is increased amount of bilirubin with yellowish discoloration of skin, conjunctiva, sclera, and the mucous membrane. What is the meaning of icterus? Icterus in Greek term means jaundice, so it's another term, icterus. Now this is the picture of a jaundice patient, yellowish discoloration of skin and conjunctiva, sclera, conjunctiva, etc. So now we'll have to know the what is the Vandenberg test for bilirubin. So yeah, we have already said that about 2 milligram per deciliter we can diagnose jaundice. So how to estimate the bilirubin in the blood? By Vandenberg test. So bilirubin reacts with the diazo reagent, that is diacetyl sulfanic acid, to produce colored azo pigment. At pH 5 the pigment is purple in color, and conjugated bilirubin being water soluble gives the color immediately, hence the name direct reaction. And the free bilirubin is water insoluble. Free bilirubin means that is produced immediately after the catabolism of heme, and that is present in the plasma. It is unconjugated bilirubin. So it is water insoluble. Then it has to be extracted first with alcohol. When the reaction becomes positive, hence it is called indirect reaction. So when you add the reagent, when you get immediately the azo purple color, that is due to the direct reaction, that is due to the conjugated bilirubin. And if you are adding alcohol, then color deepens, then that means the indirect acting, or the due to the free bilirubin which is extracted by the alcohol. So both these together will give a biphasic reaction if both are present in the serum. Now what is the hyperbilirubinemia? Depending on the nature of the bilirubin elevated, the condition may be classified into conjugated or unconjugated hyperbilirubinemia. And based on the cause, it may be also classified into congenital and acquired. So hyperbilirubinemia means the level of the bilirubin is high. So in this condition, it may be due to either acquired condition or congenital condition, or may be classified according to the type of the bilirubin which is elevated, that we have already said, conjugated or unconjugated hyperbilirubinemia. Now we have to know the normal plasma bilirubin level. For any questions in the jaundice, you have to mention the, you have to define the jaundice, and then you have to tell about the hyperbilirubinemia, and at that context you have to mention the normal level. So total bilirubin 0.2 to 0.8 milligram per deciliter, unconjugated bilirubin 0.2 to 0.7 milligram per deciliter, conjugated bilirubin 0.1 to 0.4 milligram per deciliter. The level more than 1 milligram per deciliter is called the hyperbilirubinemia. So the level of hyperbilirubinemia is above 1 milligram per deciliter. Level between 1 and 2 milligram is called the latent jaundice or subclinical jaundice. So when the level is between 1 and 2, we can call it as a subclinical jaundice or the latent jaundice. Then if the level is above 2 milligrams, then we can call jaundice or icterus. So only when the level of the bilirubin goes, total bilirubin goes above 2 milligrams, you can say that it is jaundice. So in this diagram, you can see how the pathology occurs in various types of jaundice. This is the normal picture. Then the prehepatic, where there is excessive hemolysis, more amount of bilirubin in the blood, that is free bilirubin. Then it is going to the liver, where it is conjugated. Liver has got a capacity to conjugate very large quantity of bilirubin. Then so more of conjugated bilirubin will enter the intestine, and so from there enterohepatic circulation, the quantity will be more, so more will be excreted through urine as the urobilinogen. So here you can see urobilinogen level will be increased in urine, and there will be excess quantity of unconjugated bilirubin in the blood. In the hepatic jaundice, the cause is mainly in the liver. So something wrong with the liver function. So when there is unconjugated free bilirubin, it may not be fully entering the liver because the capacity of the liver to conjugate will be minimum. So some high amount of unconjugated bilirubin will be there in the blood, and whatever bilirubin which is entered in the liver cannot be fully conjugated. So the whatever conjugated bilirubin going to the intestine will be minimum. So the enterohepatic circulation of the bilirubin also will be less, and so the urobilinogen quantity which is excreted through kidney in urine also will be minimum. That is the hepatic. So here the cause is mainly in the liver. Then the third variety, that is our concern, that is post-hepatic or obstructive jaundice, where the obstruction is occurring in the either in the liver or in the after the liver. That is conjugation is occurring properly, and the conjugated bilirubin is unable to pass through the intestine and getting reduced to stercobilinogen or urobilinogen. So there won't be any enterohepatic circulation. So the level of the urobilinogen which is entering through this systemic circulation will be minimum or sometimes even absent. So this is happen when there is obstruction to the pathway of bile from the liver to the intestine. After conjugation, the majority of the conjugated bilirubin along with the bile salts is entering the intestine, where it is deconjugated and reduced and forming the urobilinogen and the stercobilinogen. Urobilinogen going through the enterohepatic circulation and getting small quantity excreted through urine, and the stercobilinogen will be excreted through feces. So this will not happen. That's why clay colored stool and the urobilinogen in the urine will be absent, and the more the conjugated bilirubin which is produced in the liver get entered to the systemic circulation, and the conjugated bilirubin level will be high in the blood. So we are concerned with the obstructive jaundice only here, just to know what is hepatocellular, because in the second stage of hepatocellular jaundice there may be some obstructive features. So most common cause is the viral hepatitis caused by hepatitis A, B, C, D, E, C, D, G, etc. In the pure hepatocellular disease, conjugation in the liver is decreased, and hence the free bilirubin is increased in the circulation. So here the hepatitis is the cause, so the conjugation will be affected. So the unconjugated bilirubin, that is free bilirubin, will be first elevated in the circulation. However, some inflammatory edema of the cell often compresses the intracellular canaliculi at the site of bile formation, and this produces element of obstruction. So whatever conjugation occurs in the liver maybe there will be inflammation in the due to the hepatitis. There will be inflammatory edema that will compress the biliary canalicular cells, and then that will produce some obstruction. So there will be features of obstructions, that is whatever conjugated bilirubin is there, that will be leaked into the systemic circulation. So we'll get both type of bilirubin, that is free bilirubin as well as the conjugated bilirubin elevated in the second stage of hepatocellular jaundice. When the conjugated bilirubin level also increases, that calls a mixed type of jaundice results. So biphasic reaction of the Vandenberg you will get, and there is bilirubinuria also, because conjugated bilirubin, when it is enters the blood, it will be being water soluble. It may go to the through the kidney and getting excreted in the urine. So bilirubinuria also occurs. Then the urobilinogen level in the urine is either normal or maybe decreased in the hepatocellular jaundice, because in the later stage there is obstruction, so there may not be any much of the enterohepatic circulation, and so the urobilinogen level in the urine will be decreased. Now we'll pass on what all things you have to write in obstructive jaundice or post-hepatic jaundice. It is the usual question asked. Conjugated bilirubin is increased in the blood and it is excreted in the urine. That is the main thing happening in the obstructive jaundice. So after conjugation only the defect occurs. If there is complete obstruction to the pathway, then the urobilinogen will be decreased in urine or even absent. So there may not be any bile, or the bile pigment may not be conjugated by bilirubin, cannot enter the intestine for excretion through the feces as stercobilinogen, or through enterohepatic circulation urobilinogen is not formed, so the urobilinogen level will be decreased. In the total obstruction of biliary tree, the bile does not enter the intestine. That is what happening. And since no bile pigment entering the gut, the feces become clay colored. So after conjugation through bile, actually it has to reach the intestine, and there deconjugation and reduction occurs and forming the urobilinogen and stercobilinogen, and which is giving the color to the feces. But if there is obstruction, it is not going to the intestine, so what happens is the color of the feces will be of clay color. So the post-hepatic or the obstructive jaundice. Obstruction is in the passage of conjugated bilirubin from the liver to the intestine. So there is a backflow that will be increased serum conjugated bilirubin occurs. Here, this is the site where the obstruction occurs. So there will be this conjugated bilirubin will enter the systemic circulation and it will be excreted through urine also. Now, what are the causes of obstructive jaundice? There are two types, intrahepatic causes and extrahepatic causes. Intrahepatic causes, chronic active hepatitis, lymphomas, biliary cirrhosis, primary hepatoma. So these are the conditions which is occurring in the liver, which is causing inflammation and later on obstruction to the biliary passage system. Then the extrahepatic causes like stones in the gallbladder or bile duct, which is obstructing the pathway. Then the carcinoma head of the pancreas, again obstructing the pathway of bile, and also in the porta hepatis lymphadenopathy, portal lymphadenopathy, that is in the liver itself, and there is lymphadenopathy that will obstruct the pathway of bile. Post-hepatic jaundice, here you can see the various causes and all in the diagram, and then what are the biochemical changes, and how the conjugated bilirubin increased in the blood and later on it is getting excreted through urine, etc. Why urobilinogen is not seen in the urine, that is shown in here. Characterized by pale colored or absence of fecal bilirubin or urobilin, and dark urine, that is increased conjugated bilirubin. The color of the urine may be dark, so that is due to the bilirubinuria or the conjugated bilirubin excess quantities. When it is excess in the blood, it may, being water soluble, can be excreted through urine. Otherwise, normally bilirubin will never excrete in the urine. Only the urobilinogen will be there in the normal urine, only in traces amount. Never bilirubin will be seen in a normal urine. But in the post-hepatic jaundice, this may be seen. Then urobilinogen absent in the urine, and patients with obstructive jaundice experiences gastrointestinal pain, nausea, vomiting, itching all over the body. So many symptoms are there. To start with, they may be having some features of hepatitis like thing, and later on there will be features of obstruction where there is yellowish discoloration. Then the pain may be in the intestine, abdominal pain, nausea, vomiting. Then due to obstruction, then these bile salts may be entering, and that also may be obstructed, so that will produce itching all over the body. Now the laboratory findings of obstructive jaundice, LFT. Usually we are doing the blood findings for the estimation of bilirubin. LFT is done. Conjugated bilirubin or the direct acting bilirubin will be predominantly increased. SGOT or AST either normal or mildly increased. When there is infection of the liver, then there will be, or hepatitis, there will be increase in the SGOT and SGBT, that is AST and ALT. Then alkaline phosphatase will be very high. That is the typical feature of obstructive jaundice. Apart from the conjugated hyperbilirubinemia, there will be increased amount, very high amount of alkaline phosphatase, because alkaline phosphatase is usually, apart from bone, it is also secreted by the biliary canalicular epithelium. So when there is inflammation of the hepatocytes, that by canalicula get narrowed, and then due to the pressure from the epithelial cells, the enzyme will be leaked into the systemic circulation and the level will be very high. Then urine bile salt and bile pigment, both will be present. Bile pigment means the bilirubin will be present. That is, you have done the test like Faucher's test, and bile salt you are doing the Hayes test. Both will be positive in obstructive jaundice, and the urobilinogen will be absent because there is obstruction to the passage of bile to the intestine for excretion through feces or through the urine. So urobilinogen will be absent, bile salt and bile pigment present, and high level of alkaline phosphatase and conjugated total bilirubin, in which majority will be of the direct acting, that is conjugated bilirubin. So there are some tests which will detect the various types of bile pigment to know. That is, name of the bile pigment is bilirubin, urobilinogen, then urobilin or stercobilin. These are the bile pigments and the various tests: Faucher's test, Mellin's test, and Vandenberg test. So that will be positive for bilirubin. And then the Ehrlich's test will be negative for bilirubin, and also Schlesinger's test will be negative for bilirubin. Then urobilinogen, Faucher's and Mellin's test and Vandenberg negative, but Ehrlich's test will be positive. That is the test to detect the presence of urobilinogen in the urine. That is Ehrlich's test. It will be positive. Schlesinger's will be negative. Urobilins and stercobilins, only the Schlesinger's test will be positive. So just to know what are the tests, how will you do it, how can you differentiate various type of bile pigments in the urine. Then another question was the differential diagnosis of jaundice by using various laboratory findings of urine and blood. So that is, for that better to draw a table like this and then explain. So hemolytic jaundice, there are three types of jaundice: hemolytic, hepatocellular, and obstructive. And you can write first the blood findings, then the urinary findings, and fecal findings, like that. So blood sorry, then blood free bilirubin, that is unconjugated bilirubin. What happens in hemolytic anemia, jaundice, that is increased, but in hepatocellular, to start with, there may be increased. Then in obstructive jaundice, it may be normal. Then blood conjugated bilirubin will be normal in hemolytic jaundice, but it is increased in hepatocellular and also in obstructive jaundice. So in the obstructive jaundice, you can make out that is the direct conjugated bilirubin is elevated more than the unconjugated. Then the blood, other test what you do is the liver function test, mainly AST and ALT, and also ALP, that is alkaline phosphatase. AST and ALT, that is liver function test, hepatic markers, that will be normal in hemolytic jaundice because no disease condition for the liver. Only the excess hemolysis is the cause in hemolytic jaundice. Then in the hepatocellular, it will be increased because the liver is affected and infected and inflamed. So there will be increased amount of liver enzymes like AST and ALT. Then similarly, when there is obstructive jaundice also, some amount of increase may be there. There may be some infection in the liver, which may lead into intrahepatic obstruction. Then about the alkaline phosphatase, normal in case of hemolytic jaundice, and it is slightly increased in the hepatocellular because in the second stage there may be obstruction due to the inflammation in the biliary canalicular pathway. So some amount of alkaline phosphatase will be elevated. But in the obstructive jaundice, the elevation will be very high. You can see very high amount of alkaline phosphatase. Then bile salt will be in the urine. You can do the bile salt by a Hayes test. It will be absent in hemolytic jaundice, and also sometimes it may be present in hepatocellular, or sometimes it may not be there. Then obstructive jaundice, usually when there is obstruction to the bile to the intestine, it will be leaked, and so you will get a bile salt also positive. Then conjugated bilirubin, that is bilirubin will be negative in the hemolytic jaundice, and it is may be present or absent sometimes in the urine hepatocellular, sometimes present. Here it is written nil, but it can present in the second stage of hepatocellular jaundice. And obstructive jaundice, it will be very usually present. Conjugated bilirubin will be present in the urine. Then urobilinogen will be increased in hemolytic jaundice, and it will be nil or decreased in the hepatocellular, and similarly it will be absent in the obstructive jaundice. Then fecal urobilinogen, so increased in the case of this hemolytic jaundice, and it is decreased in the hepatocellular, and it is absent in the obstructive jaundice. So here in the hepatocellular, sometimes in the urine, bile salt and bile pigment may be present. So here it is written nil, but it can present. But major thing is that it is present mainly, more present in the obstructive jaundice. Depending upon the condition of the liver function, it will be either seen or it will be absent. So that much regarding the lab diagnosis of various types of jaundice. So there also you have to define jaundice. What is the criteria to diagnose a jaundice? So for that you have to mention about the Vandenberg and the level of the various types of reaction, that is direct reaction and indirect reaction and the biphasic reaction. And then you have to mention what is hyperbilirubinemia, that is above 1 milligram is called the hyperbilirubinemia. Then what is subclinical jaundice, that is between 1 and 2 is the subclinical jaundice. And then when will you call jaundice, that is above 2 milligram per deciliter, you can diagnose it as a jaundice. And then by doing all these tests, you can differentiate each type of jaundice, either whether it is due to hemolytic jaundice or it is due to hepatocellular jaundice, and also whether it is obstructive. For all these, you have to take a history of the patient, and from the history itself you can get the clue regarding the type of jaundice. Because hemolysis, there may be some history of taking one drug or something, excess hemolysis or incompatible blood transfusion or anything like that. Then hepatocellular, there may be fever, nausea, vomiting, loss of appetite in the previous, and also loose motion after taking some food from outside or something like that, then later on developing to the jaundice. And similarly, you can have an examination where liver may be palpable or slightly tender in the right hypochondrium. Like that, you can get a clue. Then obstructive jaundice, of course, same type of where the obstruction may produce some hepatomegaly, or sometimes there may be a mass in the abdomen with all the features of jaundice. And then sometimes there may be recurrent vomiting due to obstruction, and also sometimes itching due to the bile salt which is entering the circulation, producing various type of disorder. So all these things, and the management also may be differing according to the cause of the jaundice. So hepatitis usually treat with some symptomatic management, and also obstruction, if there is due to some lymph node or some malignancy, then they have to treat the condition so that the jaundice will subside. Okay, thank you.